Assalamu alaikum. My name is Dr. Fahad, and I will continue the presentation of prostate cancer. The topic of today's presentation is hormonal therapy in prostate cancer. First of all, we know the basics of hormonal control of the prostate. Prostate cells are physiologically dependent on androgens to stimulate their growth, function, and proliferation. The testis is the main source of androgen production, almost 95%, while remaining 5% is produced mostly by the adrenal cortex, which layer granulosa, reticularis, and testosterone secretion is regulated by hypothalamic pituitary gonadal axis. The pituitary gland will produce hypothalamic luteinizing hormone releasing hormone, also known as gonadotropin releasing hormone, which stimulates the anterior pituitary to release luteinizing hormone and follicular stimulating hormone. The luteinizing hormone stimulates the Leydig cells of the testis to secrete testosterone. Within the prostate, testosterone is converted to DHT 5-alpha dihydrotestosterone by the enzyme 5-alpha reductase. Dihydrotestosterone is an androgenic stimulant and more powerful and more workable than testosterone 10 times. This is a pictorial presentation. From the hypothalamus, the LH-RH is produced, which act on anterior pituitary. Anterior pituitary will produce LH, which act on the testis. It will produce testosterone, act on the prostate. Also, adrenal produce adrenal androgens, act on the prostate. Introduction of hormonal therapy. The seeds of androgen ablation therapy date back to year 1786 by Hunter, who described the seasonal variation in prostate size in animals. The impact of castration on metastatic prostate cancer is described by Huygens and Hawkes in 1941. Currently, the gold standard systemic treatment for metastatic prostate cancer is androgen deprivation therapy. It has different names: testosterone lowering therapy, castration, androgen deprivation therapy, also known as hormonal therapy for prostate cancer. The castration level. Historically, the castration level is the prostate cancer in serum testosterone level less than 50 nanograms per deciliter or 1.7 nanomole per ml. Currently, according to EUA guidelines of 2021, the method that have shown the mean value after surgical castration is 15 nanogram per deciliter. Therefore, a more appropriate level should be defined as less than 20 nanogram per deciliter, that is 1 nanomole per liter. This definition is more important as better results are repeatedly observed with lower testosterone level compared to 50 nanogram per deciliter. Different types of castration. We have surgical castration and medical castration. Surgical castration will include bilateral subcapsular orchidectomy, also called subcapsular pulpectomy. Medical castration include estrogen therapy, LH-RH agonist, LH-RH antagonist, anti-androgens, and androgen synthesis inhibitor. The LH-RH agonist and antagonist will act on the LH, which is act on the Leydig cells, while androgens will act on the adrenal androgens. We will discuss one by one each. First of all, bilateral subcapsular orchidectomy. It is still considered the primary treatment modality for androgen deprivation therapy. It is simple, cheap, and virtually complication-free, except the surgical complication, mainly the localized edema or collection. It can be easily performed under local anesthesia, and it is the quickest way to achieve a castration level, which is usually reached within less than 12 hours. It has the main drawback that it has a negative psychological effect on the male patient. Also, it is irreversible. Now start the medical castration. First of all, estrogen.
Excuse me, Fahad.
Sir.
Sir, I would like to add that prostate cancer is one of the disease that is equally important to urologists and medical oncologists too. Unlike other tumors like RCC, which is mainly fall under the domain of urologists or the surgeons. So prostate cancer is equally important to all domains of our field. Regarding the bilateral orchiectomy, it is virtually a complication-free surgery, but we have seen patients developing large hematomas or surgical skin site infections. So one should not consider it as a minor procedure. Like mostly we left this procedure to a junior most colleague doing the BSO or bilateral subcapsular orchiectomy. It should be supervised. Like we have seen, the main drawback is that we have negative psychological effect and it's irreversible. So patient needs to be consulted in detail before doing it and embarking on the minor procedure that has a major surgical, that has major psychological as well as minor surgical impact on the patient life.
And moreover, it has got a very important aspect attached to it, because the goal that you want to achieve is something which is a reflection of your dissection and the scraping of all the parenchymatous material from the capsule, the tunica albuginea. So if somebody who is a junior, who is even a senior person who hasn't done it properly, maybe leaving behind a little bit of parenchyma, that parenchyma would actually be in a position to produce the testosterone. So if you want to achieve the goal, and the goal is to have no testosterone or low testosterone after orchiectomy, that goal is not achieved. So if you are treating somebody for cancer therapy, then it should be taken with 100% say obsession, or you must have the kind of the drive that you have to provide something in totality to the patient rather than partial. So there is no place for partial kind of a thing here. For instance, if you have got a stone disease and maybe you leave behind a little bit of stone or a chip of stone, that can be taken care of later, but that is not something which can be, the analogy cannot be the same as in cancer therapy. So it should be complete. So once we have got a lot of patients who have hematocele and they present to you in post-operative clinic, you also, if you measure testosterone, sometimes, maybe most of the times, you will find that there is a little bit of tissue left behind. So whether a junior or a senior, it doesn't matter. What matters is the intention. The intention should be correct. A junior can have a very 110% intention. A senior may be too quick, or maybe he is very much busy. So it depends upon intention. Intention should be correct.
Yes, sir. 100% agreed. Like the BSO should be considered as one of the oncological surgery, not just a simple procedure of removing.
Thank you. Estrogen, mechanism of action. It will downregulate the luteinizing hormone, releasing hormone secretion, and ultimately it will decrease the testosterone production. It causes androgen inactivation. It has a direct suppression effect on Leydig cells function. Also direct cytotoxicity, which is tested in vitro. Most commonly used estrogen is diethylstilbestrol, DES is commonly used estrogen in the dose of 1 mg oral form and up to 3 mg. However, it has fallen out of favor due to associated risks, mainly cardiac toxicity and adverse cardiovascular events. Hence, it is not recommended as first-line option for androgen deprivation therapy in prostate cancer. Second is luteinizing hormone releasing hormone agonist. They are preferred method for androgen deprivation therapy first line in prostate cancer. Why? Because they stimulate the pituitary to produce more luteinizing hormone, which causes initially an elevation in the testosterone production within the testis, which is known as flare phenomena. We will discuss later. However, prolonged exposure eventually causes pituitary receptors to downregulate, and ultimately testosterone is reduced and stopped. Currently, FDA approved 4 LHRH agonists for clinical use, which include goserelin, triptolin, histrelin, and leuprolide. Flare-up phenomena. The first injection of LHRH agonist induces a transient rise in luteinizing hormone and follicle stimulating hormone, leading to testosterone surge or flare-up phenomena. It usually starts 2 to 3 days after the administration of first injection, and it lasts for about 1 week. This mainly leads to detrimental clinical effects with advanced disease, which include increased bone pain, acute bladder outlet obstruction, obstructive renal failure, spinal cord compression, cardiovascular death due to hypocoagulable status. So we use anti-androgens, that is cryptopteron, started on the same day of injection and lasting for about 4 weeks, which can be used to counteract this flare-up phenomena.
Fahad, can you go to back?
Sir.
Sir, I had a query. Like we have seen that the flare-up phenomena, it starts 2 to 3 days after administration and lasts for about 1 week. Then I had a query: why anti-androgens are given for 4 weeks?
Because it starts 2 weeks earlier and it lasts 2 weeks later. So it is basically for 4 weeks because some of the receptors are occupied by the hormones. So it is just because of the reason that you need a little bit of time for the conformational change on the receptor side. So that is one explanation.
And the anti-androgens, they don't completely, I will say, diminish or the rule out the flare-up phenomena. They just lower the incidence or chances of flare-up phenomena. So do we often see the flare-up phenomena while giving the LHRH agonist along with the anti-androgen?
Right. So you see, actually, the experience of giving the agonist was earlier than the prescription of sapropterin acetate or anti-androgens. So flare-up phenomena was something which was there on the horizon in the late 90s and early 90s also. But at that time, it was something to be reported by some patients, and many of the patients, they just hang around with this kind of phenomena, and they used to have these kind of experiences, but it weans off with the passage of time. So it's not necessary to cover it. It is sometimes covered. It's a better practice to cover it, but it is not necessary. So if you don't want to cover it with anti-androgens, you are right on track. So it is something which is observed in the early 2000s, and then it made a kind of a practice that we must prescribe this thing for every patient. But if somebody is not doing it, then it's okay.
LHRH antagonist. These drugs compete for and bind to the LHRH pituitary receptors, preventing the normal signals for testosterone production reaching the testes. This causes a rapid decrease in LH, FSH, and testosterone production. And it has an advantage, it does not causes flare-up phenomena. However, they are associated with histamine-mediated side effects, which includes allergic reactions, which in many cases have been serious. Example, anaphylactic shock, particularly so with Aberrelix, and Degrelix lessens the risk. Their benefits over more traditional LHRH agonists are yet to be proven. Anti-androgens, they have a similar structure to testosterone and bind with the testosterone receptors on the prostate cells, blocking the effect of testosterone. They are in the form of oral compounds and classified according to their chemical structure into two main groups, the steroidal group and the non-steroidal group. The steroidal group include cryptopyrrone acetate, megestrol acetate, and medoxyprogesterone acetate. The non-steroidal or the pure group include nalitamide, flutamide, and bicalutamide. First, discuss steroidal anti-androgens. Steroidal anti-androgens have progesteronal properties leading to central inhibition by crossing the blood-brain barrier. Progesterone properties which help to lower the testosterone level. So loss of libido may still an issue with steroidal anti-androgens. Their main pharmacological side effects are secondary to castration, which include gynecomastia, but in rare cases, while non-pharmacological side effects include cardiovascular toxicity, which is 4 to 40%, and hepatotoxicity. The next group of anti-androgens are non-steroidal. They don't lower the testosterone level. Therefore, the issue of libido, overall physical performance, and bone mineral density are more likely to be preserved with non-steroidal anti-androgens. They are not without side effects. They have include gynecomastia, breast pain, hot flashes. Liver toxicity is also with non-steroidal anti-androgens. Among them, bicalutamide has shown a favorable safety and tolerability than flutamide and nalitamide.
Now, one more thing about steroidal anti-androgens, particularly megestrol acetate, which is by the name of Megace. It is something which is prescribed to enhance the capacity to eat. For instance, somebody is having anorexia and loss of appetite, you can prescribe this thing. So these patients who have got Megace in their regimen, they tend to increase their appetite and they increase their weight. So they become bulky. So this is one of the things that is kind of a side effect. This drug is also used in geriatric population, in those people who are more than 70 years of age, who have got loss of appetite. So if we want to have a patient to have a good appetite, this drug is actually prescribed. So all those progestational drugs which are used, they tend to increase the weight in gynecology also.
The fifth group of medical castration include androgen synthesis inhibitor. They inhibit the androgen synthesis at all levels, in the testis, in the adrenal cortex, and within the tumor cells of the prostate. They block testosterone production by inhibiting the enzyme called CYP17 that produces testosterone from the cholesterol. The 3 androgen synthesis inhibitor approved in United States will include ketoconazole, aminoglutamide, and abiraterone acetate. Now we will discuss their side effects of androgen deprivation therapy. Hot flushes, also known as flashes, can significant, very bothersome and distressful, can disrupt the daily activities and the plans of the patient. Among them, medroxyprogesterone is an effective treatment with limited side effects. It causes anemia, mostly the normocytic normochromic, and is very common among patients who have taken androgen deprivation therapy. Fatigue is a common symptom and it has multifaceted. Can be related to a reduction in testosterone, but also due to related other treatments, physical and psychological factors. Moreover, the androgen deprivation therapy causes cognitive decline, which include forgetfulness, lack of concentration, and mood changes. Also, patients complain of sexual dysfunction and loss of libido, and drugs that block testosterone action rather than decrease its level may be used if a man is concerned about this, but they not be as effective in terms of disease control. Long-term use of androgen deprivation therapy will produce osteoporosis due to bone mineral density is reduced as testosterone level is decreased in the body. Increased risk of weight gain and obesity as lean muscle mass reduces and fat mass increases. Opposite effect of testosterone, especially around the tummy area. Increases the risk of sarcopenia, a term used to describe the erosion of skeletal muscles and general fragility, feeling weak, can increase the risk of falls and further increase the risk of fracture. Hormonal therapy also increases serum testosterone and triglyceride levels, so they can increase the risk of cardiovascular complications. This is the summary of we have discussed the now we will discuss at which levels they will act on. Estrogen, the diacetylestilbestrol, act on the pituitary. It is given in the oral dose and a dose of 1 or 3 mg, and it is given daily. Ghrelin, leuprolide, hysterin also act on pituitary. Few are given subcutaneous and few are given intramuscular, and they are given every 1 to 3 months, every 1 to 6 years. The androgen and inhibitor will act on the adrenal, which include ketoconazole, aminoglutamide, and abiraterone. They all are given in the oral forms, and they are given daily or 4 times a day. While we have discussed for testis, we will do subcapsular orchidectomy. And the others, biglutamide, flutamide, nucleamide, will act on the prostate cells. They are also in the form of oral, and they are given also daily. This is another summary. Discuss the LHRH, GnRH agonists, which include the leuprolide, ghrelin, triptolin. They act on the pituitary. Mechanism of action is stimulate the release of LH, feedback loop of ultimately decrease the LH production, mainstay therapy for metastatic cancer, and decreases the LH level, and also considerable side effects. The GnRH antagonist, which include deglelix, abirelix, and cetrelix, act on the pituitary gland, bind to the receptors, and block the release of gonadotropin releasing hormone. They prevent the testosterone surge, the flare-up phenomena, which and also leads to decrease in FSH. They also have a considerable side effects. Adrenal targeting drugs, which include the ketoconazole, abiraterone, glutathione, will act on the adrenal gland. They decrease the androgen production from the steroid precursors by blocking the cytochrome P 450 enzymes. They have a selective CYP17 inhibitor administered with low dose prednisone. Side effects can include hypertension, edema, and hypokalemia. The androgen receptor antagonist, first generation and second generation. First generation include flutamide, nalitamide, and biglutamide. Second generation include enzaclumide and epiclumide. Both act on the prostate cancer cells. First generation are non-steroidal anti-androgens. They inhibit the binding side of the testosterone and dihydrotestosterone to the androgen receptors. They are not recommended as monotherapy, as also associated with gynecomastia. The second generation will block androgen receptor, minimizes the nuclear translocation of androgen receptor, and diminish the androgen receptor mediated transcription. They are associated with falls, fatigue, and decreased appetite. 5-alpha reductase inhibitor, which include the finasteride and detasteride, which also act on the prostate cancer cells, inhibit the conversion of testosterone to dihydrotestosterone, but they are used in BPH. They have not indicated in the prostate cancer management therapy yet. That's all. Thank you.